Hello, everyone. Welcome. My name is Wendy Xie, and I am a project manager at the National Collaborating Center for Infectious Diseases. I would like to welcome you to this webinar, where we will talk about the new guidelines for the economic evaluation of vaccination programs in Canada, produced by the National Advisory Committee on Immunizations at the Public Health Agency of Canada. I would like to first acknowledge that the National Collaborating Center for Infectious Diseases, or NCCID, is hosted at the University of Manitoba, which is situated on the ancestral lands of the Anishinabeg, Anishinaabeg, Dakota, Dene, Nehethawak, and Niniwak nations. It is also in the heart of the homeland of the Métis Nation. I am joining this webinar from the unceded lands of the Anishinaabe Algonquin Nation. At NCCID, we strive to honor the lands and their original caretakers in our work. We acknowledge that we are on Treaty 1 land. We recognize that this and other treaties have been implemented as a part of the process of colonization intended to benefit some while harming others. We are committed to working with our partners towards reconciliation. Just a few housekeeping items before we begin our presentations. We'll be using the chat tab for communication with attendees, so please check there for any updates. If you have technical problems with Zoom, please send us a message using the email provided in the chat box or nccid@umanitoba.ca. This webinar is taking place in English with French interpretation, and you can find the French side using the interpretation or the language tab below. You can just select French. If you would like, you can listen to only French by clicking on mute original audio. Please leave any questions you have for the speakers in the Q&A tab, and we will try to get through as many as possible after the presentations. Just a reminder to participants that you can give a thumbs up to any question in the Q&A tab to push it up in priority. Finally, the recording of this webinar, as well as a copy of the presentation slides, will be available on the NCCID website under the webcasts tab after the event. And now I would like to introduce our speakers. Joining us today are Dr. Beata Sander and Manuel Young. Beata Sander holds a Canada Research Chair in Economics of Infectious Diseases. She is a senior scientist at the Toronto Health Economics and Technology Assessment Collaborative at Toronto General Hospital Research Institute within the University Health Network. And she is a professor at the Institute of Health Policy, Management and Evaluation at the University of Toronto. She holds appointments as adjunct scientist at ICES, formerly known as Institute for Clinical Evaluative Sciences, and Public Health Ontario. Manuel Young is a senior health economist at the Public Health Agency of Canada. Prior to this role, Manuel had worked at different health technology assessment and public health agencies, including Health Quality Ontario, which is now Ontario Health, the Canadian Agency for Drugs and Technologies in Health, as well as Public Health Ontario. We'll be starting this webinar with Manuel's portion of the presentation today. Thank you, Manuel, and I will be passing the mic on to you.
Great. Thanks, Wendy. Thanks for that kind introduction. And welcome, everyone. And we're really excited to present some recent work from the National Advisory Committee on Immunization, also known as NACI. Beata and I are both based in Toronto, so we wanted to acknowledge that Toronto has been the traditional territory of many nations, including the Mississaugas of the New Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. We do not have any conflicts of interest to declare. Now, for this presentation, there will be 4 components. First, we'll talk about an overview of who NACI is. Then we'll talk about who the Economic Guidelines Task Group, or EGTG, is. And then we'll get into the crux of the guidelines themselves and talk about some of the highlighted chapters. And finally, we'll end off with application and next steps. Now, before we jump into the guidelines themselves, let's take a step back and look at where we, NACI, is situated in the federal health portfolio. So we are within the Public Health Agency of Canada, also known as FAC, and we are one of the 3 agencies that are under the direct purview of the Minister of Health. The Minister of Health also oversees 2 arm's length organizations. In Canada, various decision makers assess economic evaluations of vaccination programs. So at the federal level, they include us at NACI, and at the provincial and territorial level, they include health ministries, and depending on the jurisdiction, there may also be provincial immunization technical advisory groups. NACI provides non-binding advice to the provinces and territories, who in turn make decisions on implementation of these vaccination programs. Such decisions can include whether to publicly fund a new vaccination program, how to roll out the actual program, and how to strengthen and monitor existing programs. So NACI was established in 1964 by the Government of Canada. We used to be housed under Health Canada before FAC existed, and NACI provides public health advice relating to vaccines used for the prevention of disease and certain prophylactic agents for humans. The committee has experts in infectious diseases, in allergy and immunology, in geriatrics, nursing, pharmacoeconomics, public health, preventative medicine, epidemiology, and social sciences. Now, the scope of NACI has traditionally included vaccine characteristics and epidemiology for the basis of its vaccine recommendations. However, as of 2019, NACI's mandate is gradually being expanded to include other programmatic factors, such as program feasibility and cost effectiveness. The expanded mandate came about because of feedback from the provinces and territories and a desire to build capacity at the federal level. So the objective of this expanded mandate is for Canadians to have timely and equitable access to immunization. Having a more integrated and timely NACI guidance, combining the scientific and economic evaluation considerations, will accelerate program immunization decision-making. As alluded to before, the provinces and territories have discretion as to whether to accept NACI's advice. And some of the provinces and territories have their own technical advisory committees that may complete complementary analyses. So for example, Quebec and Alberta has such committees. Here we see the flower diagram showing key considerations for NACI's recommendations. On the left-hand side, we see the factors that are traditionally considered in vaccine recommendations prior to the NACI expanded mandate. So for instance, we ask, what is the epidemiology and the burden of disease related to this vaccine preventable disease? What is the efficacy and the effectiveness of the vaccine of interest? What is the immunogenicity? So the magnitude, the type, and the duration of the immune response. And are there any safety signals following administration of this vaccine? On the right-hand side, we see the new and additional factors that are being considered as part of the NACI expanded mandate. We are asking, is this vaccine program acceptable? Is there a high level of demand for it? Is the program implementation feasible to roll out given the existing resources? Is this vaccine program improving health equity or equity in general? And have ethical considerations of this immunization program been adequately addressed? And of course, finally, economics. Will the vaccine program be cost effective relative to other existing options? Here we see the life cycle of a vaccine. In the first stage, there is research and development through collaborations with industry, academia, through FAC and other government departments. A developed vaccine product then goes to the regulatory body, Health Canada, for approval on whether it can be sold on the Canadian market. Once a product receives Notice of Compliance, or NOC, NACI conducts its review based on vaccine characteristics and epidemiology. prior to the expanded mandate, we would have the provinces and territories who then review cost effectiveness, feasibility, equity, etc. But given the expanded mandate, NACI now also assesses these considerations. We conduct consultations with provinces and territories via the Canadian Immunization Committee, or CIC. And this table is where vaccine program managers and decision makers sit. Please note that for NACI reviews, they're not necessarily for one product at a time. A statement could review multiple products and assess their optimal use in the current landscape. And then next part of this diagram, we see the implementation and supply management phase. So provinces and territories deliver on vaccination programs. FAC supports supply management, and the Public Services and Procurement Canada is responsible for bulk procurement that is happening for the country. And at the final stage, there is program evaluation and surveillance conducted by FAC and Health Canada. And the information generated from here then feeds back into research and development, and as well as to NACI's potential update or reassessment of a vaccine program. As we previously saw, NACI can begin a review when there is a new vaccine product for a vaccine preventable disease of high importance. But there are also other action triggers. For example, if there is a new indication, if there is a supply issue, if there is an outbreak or a change in disease burden, if there are program implementations such as cost and operational issues, or if there are requests from provinces and territories, from the public and from providers. So given these action triggers, a working group can be initiated. NACI would assemble this working group made up of both NACI members as well as external subject matter experts. And where possible, we would include an expert on pharmacoeconomics. The working group is supported by Secretariat staff members who are the ones to conduct the evidence syntheses or the economic analyses for the working groups, for the working members to deliberate upon and to base the recommendations upon. There can be up to 3 streams of work within a NACI statement. The first stream is on burden of disease and vaccine characteristics through scientific literature reviews. The second stream of work is on EFA, what we call EFA, so ethics, equity, feasibility, and acceptability considerations. And the third stream of work is on economic analyses. If we branch out to the process for economic analyses, there are 3 stages. First, we determine if there is even a need for an economic analysis for the file. And we use a prioritization exercise to help us determine this. We are consulting with NACI members, we're consulting with provinces and territories via the Canadian Immunization Committee, and we are getting that feedback to determine which files require economic analyses. If the file does require economic analyses, we then determine the approach. We are conducting an environmental scan at this stage, and we're trying to see what existing literature there is. And we're trying to determine what type of product or what type of information is needed to go into the evidence package for NACI members to review. Would a systematic review of economic evaluations be sufficient, or do we need a model-based economic evaluation to support this work, or do we need a multi-model comparison to support this work? And once that decision has been made, we move on to the third stage, which is to actually conduct the work. And at this stage, it is an iterative process with our various experts collecting their feedback and using the various tools that we've developed to support this work. So we have reporting guidelines, we have presentation templates, we have guidelines on how to conduct a systematic review for vaccination programs, and we also have the crux of today's presentation, which is the guidelines on how to conduct a model-based economic evaluation. As alluded to before, one part of our evidence package could be a multi-model comparison. And essentially what this means is that we are comparing two or more models. One of the models will be a FAC model that we either develop de novo or adopt from somewhere else. And the other models could be developed or funded by those in academia, those in government, those funded by another recognized funding agency, or those developed by industry. And what we're doing is we're trying to assess the model structures, their inputs, their assumptions and results, and see if there is convergence or divergence. And we are trying to assess if the different assumptions and inputs are, and we're trying to assess how these different structures and inputs and assumptions are affecting the conclusions of the model. Currently, for the multi-model comparison, we are in a piloting phase. Now, we had convened this Economic Guidelines Task Group, or EGTG, to help support the expanded mandate and to develop guidelines for economic evaluations of vaccines in Canada. And these guidelines inform best practices and promote standardized and high-quality evidence for decision-making. The reason for needing this new set of guidelines is because existing guidelines are not specific to Canada. So the WHO and the US panel are existing major guidelines that are not specific to Canada. And the other set of guidelines from CADTH, the Canadian Agency for Drugs and Technologies in Health, they're not specific to vaccines. The scope of this work includes conducting and reporting of model-based economic evaluations. It does not include budget impact analyses or the decision-making process. The target audience of these guidelines are researchers that are conducting this type of work, mathematical modelers, as well as end users of the generated results, so policymakers and others. Here are the members of the Economic Guidelines Task Group. Our co-chairs are Dr. Beata Sander and the late Dr. Murray Cron. We also have Dr. Lisa Prosser from the University of Michigan, Dr. Mark Jitt from the London School of Hygiene and Tropical Medicine, Dr. Sterling Bryan from the University of British Columbia, Dr. Sachi Ozawa from the University of North Carolina at Chapel Hill, Dr. Werner Brouwer from Erasmus University of Rotterdam. And we also have two liaison representatives. We have Karen Lee from the Canadian Agency for Drugs and Technologies in Health, and Dr. Monica Naus from the BC Centre for Disease Control, representing provinces and territories. So the members here represent both Canadian and international experts in health technology assessment, guidelines development, mathematical modeling, childhood health, and infectious diseases. During the development process, we had reached out and consulted with many stakeholders. Of note, we had an academic peer review process with both Canadian and international experts in health technology assessment and health economics. And we also had a public consultation process where we had provided webinars and an online survey back in 2022. And some of those stakeholders included, but not limited to, industry, patient groups, economic guideline groups, health technology assessment agencies, and the general public. Now, before discussing the content of the guidelines, I wanted to bring to the forefront the differences between vaccines and other health technologies, like drugs, medical devices, surgeries, or any other health intervention. So vaccines can have broad impacts that are unique to vaccines or are unusually large. So for example, vaccines can affect both the vaccinated and unvaccinated individuals. And we call these externalities. Externalities are costs and consequences of an intervention that fall on other members of the population beyond those receiving the intervention. We also have intergenerational effects. we have some of these externalities that are vaccine specific, like herd immunity or community immunity. We have age shifting of disease. We have serotype replacement and disease eradication. We can also have externalities that are affecting caregivers and family members and household members, such as so specifically the social network of patients. And these type of spillover effects are a type of externality. Vaccines can also have non-health impacts. So vaccines can affect productivity, it can affect consumption, education, the environment. So for example, vaccination programs can improve educational outcomes by preventing neurologic damage from measles. It can increase the productivity of an individual by preventing influenza, or it can decrease the level of residual antibiotics from vaccine use. So, excluding these broader impacts of a vaccination program can undervalue these vaccination programs. So this is why it's important to have these new set of guidelines outlining what to do and how to conduct this model-based economic evaluation in the context of vaccination programs and in the Canadian context. There are 15 chapters in total for these guidelines, and they go from how to conceptualize the decision problem all the way to how to report the results. And these are the chapters that will be highlighted today: types of evaluations, perspectives, modeling, equity, and the impact inventory table, as well as our reference case. So with that, I will pass it on to Beata.
Thank you so much, Manwa, and thanks so much, Wendy, for the kind introduction. So for the next part of our presentation, we will go through the highlighted chapters and the specific recommendations, and we will also do a little bit of kind of introduction to economic evaluation for those who haven't had the experience quite yet. So next slide. Thank you, Manwa. So if you recall the different types of economic evaluations, and we are listing here cost effectiveness analysis, cost utility analysis, cost benefit analysis, and cost minimization analysis. And then in the middle and the right column, we're looking at how do we measure outcomes. And so in the middle column, we talk about cost. And so you see we measure costs in any type of economic evaluation, which usually would include costs for the intervention, as well as costs for the disease that we are preventing. And I will talk a little bit more about that in a little moment. Okay, so then if we look at how we measure or value health outcomes, that's where the different methods are different. So for cost effectiveness analysis, our outcomes are natural units, which most of the time it's a number of cases avoided, number of deaths avoided, number of hospitalizations avoided, or life years gained, or any other type of clinical outcome. For the second type of analysis, cost utility analysis, we use quality adjusted life years as an outcome. And quality adjusted life years basically will standardize our health outcomes into one single metric, which allows us basically to compare different interventions across one disease area or different interventions across different disease areas. So we could make comparisons about cost effectiveness of different vaccines for different diseases, for example, HPV or pertussis or malaria or any other type of disease. And outside of the vaccines, we could then also compare the cost effectiveness of a vaccine to prevent some specific disease to interventions, for example, like a new cancer treatment that would extend life and improve quality of life for patients with specific cancer. So basically allows us to make comparisons across interventions and across different diseases, because now we would have the same outcome. There's cost benefit analysis. Sorry. Cost-benefit analysis. Here we value outcomes in monetary terms. And so this goes beyond just looking at the cost. So say, we have a vaccine, we prevent specific disease, maybe people do no longer need to be hospitalized, so we reduce overall hospitalization costs, but we also improve health. And so that improvement in health, we could also value in dollar terms. And that's what cost-benefit analysis is about. And then finally, cost minimization, which is something that we see very, very rarely because the underlying assumption is that both interventions, or if you compare more than two, all interventions that are compared would have the exact same effectiveness. And that refers to the effectiveness of the intervention, but also potential adverse events and also potential other kind of things that are important to patients, like how often or do I need to take a treatment? It could be a drug that's equally effective, but maybe one is taken twice a day and the other one is taken 6 times a day. So patients may prefer the one that's you only need to take twice a day. So very, very unusual that two treatments are exactly the same in terms of effectiveness, adverse event, and how the intervention is delivered. But if that were the case, then we basically just want to minimize our cost. Next slide, please. Okay, thanks, Mama. So here we are looking at quality adjusted life years in a little bit more detail. So basically, as I said already previously, it's a summary measure that quantifies the effectiveness of an intervention by combining gains in quality of life and quantity of life. So if you live longer, it's included. If you improve quality of life, it's also included all in one. And so the way this works, if you look at the figure, so we map out remaining life expectancy, and we value health on a scale between 0 and 1, where 0 would be equivalent to being dead, and 1 would be equivalent to perfect health. And so you can imagine that, say, if I had influenza today, my quality of life would not be perfect. So it would be somewhere between 0 and 1, depending on how severe my disease is. And then can change over time, depending on the health states we are looking at. And so generally, there are different ways of how we can measure health utilities. There are different instruments, and you can read more about it. We do discuss this a little bit in the guidelines, but there are also many books and articles that talk about it. But so generally, there are direct and indirect measures. And I think that's all we need to know or go into for today here. So if we look at the next slide, so once we kind of map out our remaining life expectancy, and we map out what's the quality of life at specific point in times, then what we do to calculate a quality is basically multiplying the utility of a health state with the duration of time, that the time we spent in that health state. And so if we have a health state, like on the left-hand side, we are in perfect health for 1 year, that would give us 1 quality adjusted life year. If we are not living in perfect health, let's say we have some chronic disease that reduces our quality of life by 50%, so our utility is 0.5, and say we live in that particular health state for 2 years, then this also would give us 1 quality adjusted life year. Okay, so with this, going into chapter 2 of our guideline statement, where we talk about the types of evaluation. And so the recommendation and the guidance is that in the reference cases, the economic evaluation should be a cost-utility analysis with outcomes expressed as quality-adjusted life years. And any departure from this approach should be clearly justified. The second recommendation is that a cost-benefit analysis may also be used alongside the reference case in situations where the vaccination program may be compared to a non-health intervention. So for the first statement, we do allow a departure from cost-utility analysis because there are are not, because for some populations, we don't have valid instrument to directly measure utilities. So that's the case, for example, for children under 8 years of age. And so analysts may prefer then using some different approach, like a cost effectiveness analysis, instead of using a cost utility analysis. However, if this is something that's being done, then we should justify why we choose this approach. And we added cost benefit analysis because vaccines are a public health intervention that could be compared to other public health interventions that may be non-health interventions but have an impact on health or otherwise. And so we want to allow to also conduct cost benefit analysis, but it should be in addition to the cost utility analysis. Next slide, please. Okay, so here we're looking at perspective, and that's what I mentioned previously, where we're thinking about what goes into our analysis and how broad or how wide do we cast our net. And perspective is the perspective of basically the decision maker. So whoever will review this economic evaluation that we are conducting and kind of looking at it, and they have different perspectives, obviously. And so you see the smaller circles in that figure, for example, a patient perspective, where we would look at the costs to the patients and their families or caregivers. The typical perspective that's used is the healthcare payer perspective, which would be costs to a publicly funded healthcare payer, or generally our ministries of health. And then the broadest perspective is what we call the societal perspective. So that basically includes all costs and all health outcomes, independent of who pays. So that includes broad categories like productivity loss or consumption, other costs to the government, costs to the patient. So we basically don't care who pays. We want to see all the impacts in our analysis. Next slide, please. And so in our statements, our recommendation is that we conduct 2 reference cases. So 2 reference case analyses should be presented as part of the economic evaluation of vaccination programs. One conducted from the publicly funded health system perspective, and that would include healthcare clinical services as well as public health, and the other from the societal perspective, which would include basically everything. And our second statement recommends to include both cost and outcomes consistent with the perspective that's stated. So everything that's relevant for the health system perspective should be under that perspective. Everything that's relevant for a societal perspective, obviously want to include there. And so in the next slide, we can see that this is consistent with recommendations in several jurisdictions. So for example, the WHO guidelines that are aimed for low, middle, and high income countries, and those that are specific for vaccines, state that the perspective should be in accordance with the national guidelines in the country, but also from a societal perspective. The US panel also recommends now both healthcare sector and societal perspective. In the previous version, they were only recommending a societal perspective. And CADIS, a Canadian Agency for Drugs and Technologies in Health, is recommending the perspective of a publicly funded healthcare payer. And that is relevant. This is very relevant in our context because now we have basically guidelines in the Canadian context for drugs and technologies or devices and so on in health that are recommended from a publicly funded healthcare payer perspective to be conducted. From that perspective, we are expanding this for vaccines to include the broader impact that vaccines have and fully account for all the impacts that vaccines have by also recommending a societal perspective in addition to the health system perspective. However, for given that both Canadian recommendations include a health system perspective, that allows us to compare across different interventions in Canada. Next slide. One thing I do want to highlight is our impact inventory. That's at the end of the guidelines. And so the purpose of this inventory is to provide a comprehensive list of health and non-health impacts, so that researchers who are conducting the economic evaluations basically can go through and think about what may be relevant in their analysis, and then also kind of check off of what's included and what's excluded. Sometimes, there are different reasons of why we may or may not include something. And so maybe we couldn't include something because we're limited in time to conduct the analysis, and maybe we don't have the data or this and that. So this gives us space where we can also write some comments, say, we were unable to include it, but we think the impact is ABC. And so this is just an excerpt. So it's quite a long table, and it goes into different categories, and it basically includes impacts on health outcomes, on health system costs, on direct out-of-pocket costs, on losses in productivity, and impacts on consumption, and then also impacts on education, social services, community services, the environment, and other areas. And especially in the last category, you probably can see that it might sometimes be challenging to value some of those outcomes. So how do we value an impact on education? So there's some research on that. But also, how do we value an impact on the environment? So Benoit talked previously about antibiotics, so maybe vaccines. Fewer people are sick with infectious diseases. Maybe we use fewer antibiotics, or maybe less antibiotics in the environment. But then how do we actually estimate that? And so some of those things become really, really challenging. And so that's why we also have this impact inventory table, where this can be noted that it's probably, we can say there might be an impact, or there is an impact, but we are unable to value this in monetary or other terms. Next slide. Okay, chapter 8 talks about modeling. And so there are different ways of how we can think about modeling and the different types of models. We talk about infectious diseases. Our main distinctions is between dynamic models and static models. And so with dynamic model, what we generally mean is dynamic in a way that it includes transmission of infection. And so we want to use dynamic models when there are externalities. And what we mean here is, especially if there is an impact on the prevention of human-to-human transmission of infection. So basically, if there's any kind of herd or community immunity effects, we want to use a dynamic model. In some circumstances, some diseases, if we vaccinate one specific age groups, we may actually shift the incidence of that disease to a different age group, which might be at greater risk, for example, for more severe sequelae. We have an age shifting of disease, so we would want to include that in our analysis. Or serotype replacement. So say, for example, if a vaccine prevents some serotypes that cause that disease, but not all of the serotypes, then we know that what often happens is that we may reduce disease due to some group of serotypes or serogroups or strains, but then there is a replacement with other strains or serotypes or serogroups that would cause disease then. So there's some kind of replacement. For example, streptococcal pneumonia is one of the models we've been just looking at. So dynamic models, if there's any of those type of externalities. Now, the hardcore infectious disease modeler probably will say we always need dynamic models, but we also want to, but I do think it's not always absolutely necessary. So there are circumstances where we talk about a infectious diseases, but where there is no human-to-human transmission, for example, tetanus or rabies. Sometimes the intended group for our vaccination program is not epidemiological super influential with respect to transmission, like vaccination of healthcare workers or vaccination in the elderly, where there is less transmission to other population groups than, say, we vaccinate kids. Sometimes the individual is already a host, so we already carry that that strain or that pathogen in us. So, for example, varicella zoster is a good example for this, where herpes zoster or shingles occur later in life due to reactivation of latent infection that had followed primary varicella or chickenpox infection. Sometimes the vaccination program has been demonstrated to be highly cost effective, and so you would adding a dynamic modeler to that, or has been demonstrated highly cost effective in a static modeler. So what a dynamic model would potentially add is just the herd immunity effect, so preventing more disease, which would make it intervention even more cost effective. And so there is not necessarily a need to go into dynamic modeling. And then sometimes it might be important to do a dynamic model, or maybe there are externalities like herd immunity effects, but maybe you need to prepare some model for decision making, and there's a tight deadline, and maybe it's not possible, but there is data that would allow us to approximate that effect. And then we may not want to go and try we may not want to go into dynamic modeling. So there are situations where a static model is kind of like good enough or fit for purpose in that way. So other than static versus dynamic, there are other considerations. They're listed here: it's deterministic or stochastic, aggregate level or individual level models, or open and closed populations. And we talk a little bit more about that in the modeling chapter, so you can look that up. There are really nice flowcharts. One is by Mark Jit and Mark Brisson on the left-hand side, and on the right-hand side, you see the WHO guide. So you can look that up. It's referenced in the guidelines as well. But so they're really helpful in kind of going through this flowchart to determine what might be needed, or whether or not we need a dynamic model or a static model might be appropriate for the question that you have. So finally, I want to talk briefly about the equity chapter. That is new compared to other guidelines. And so actually, we're really excited about having this included. But just read the statement. The first recommendation is that researchers and decision makers should work together to establish which equity dimensions and goals should be included in the economic evaluation of the vaccination program being considered. And it should be considered in the context of NACI's EFA framework. And so we are listing here as equity dimensions and goals that have been identified by NACI. And our second statement is that analysis that incorporates relevant equity concerns should accompany the reference case analysis. For example, can use distributional cost effectiveness analysis, extended cost effectiveness analysis, or other emerging methods that are presented alongside the reference case. And I want to state that we acknowledge that methods to include equity in economic evaluations are still under development. So it's an area of active research. There are some methods, there's quite a bit of progress being made, but it's not fully established yet. And so it's a recommendation that's something that we would like to see, but where we acknowledge that it might not be entirely possible to conduct it. But so at the minimum, I think what is really helpful to the committee is to kind of stratify analysis by equity relevant variables. And we already do this. Often we do analysis for different age groups, or some kind of definition of a higher risk or lower risk group. So we usually do this by biological variables. And we could imagine to do something similar by equity relevant variables, for example, by any type of social determinant of health variable, for example, or by geography or other types of considerations. Next slide. And so the next two slides really just summarize all the different chapters. So if you look in the guidelines, this is kind of like the quick kind of a guide where it walks basically to all the different considerations and specifies the guidance. And it goes from how to be develop or come up with the decision problems to the different types of evaluation, study population, comparator, perspective, time horizon discounting, measurement and valuation of health, resource use and cost, and then how to conduct the analysis, uncertainty analysis, and consideration of equity. So this was it for the specific chapters in the guidelines that we thought we wanted to highlight today. So what's next? So basically, the guidance is used by the NACI Secretariat for items in the work plan that require a model-based economic evaluation. So it provides guidance to the NACI Secretariat analysts on conducting economic evaluations and standardizing the economic evaluations that are reviewed by NACI. We encouraged the use of the guidelines by health economists, mathematical modelers in academia, the provinces and territories, industry, and anyone else really who is conducting economic evaluations to support decision-making at NACI, but also generally, I think people might find it helpful if you conduct an economic evaluation on vaccines. We've planned a couple of next steps. So one is to create a worked example so that it's easier for other analysts to kind of follow the steps and kind of just look step by step. How do we actually do this? We've developed already actually an interpretation guide for decision makers, which is not up on the website yet, but I think it's coming hopefully soon. And then we have a list of, we aim to develop a list of commonly used societal costs and consequences. And so that is really to support the societal perspective that we are recommending, which we know is new to many analysts in the Canadian setting. And so we want to facilitate uptake of basically doing evaluations from a societal perspective by helping kind of with the data that goes into that. And of course, there will be future revisions that may be triggered either by methodological developments in the field of health economics or by updates, particularly of the CADIS guidelines, as well as any areas that NACI would identify that need some kind of update or clarification or any kind of revision that was identified working with those guidelines. And so we'll finish with a very, very long list of acknowledgements and like a big thank you to so many people who have contributed. As peer reviewers, as equity experts, Indigenous Services Canada, economics, the NACI Economics Task Group, other NACI member who contributed, project management support provided by the NACI Secretariat, Public Health Ethics Consultative Group, contractor Nina, who been drafting the first version, and of course, how many contributors, including Manwa. So thank you very, very much, everyone. And I think this is it from our side. Thanks.
So thank you so much, Viera and Manwa, for your presentation. We have a bit of time left for the question period. We have first one question from Matt in the Q&A tab. Matt is wondering, we are doing modeling to support the CAF's vaccination decisions. We're getting into modeling impact on QALYs, the quality adjusted life years, et cetera. But there are a bunch of underlying models that we are unclear on. Example, whether there are standard assumptions for risk of death that doesn't result in some people living unrealistically long. And he's wondering, and I know, Beata, you mentioned briefly the calculations for the quality adjusted life year, but do the guidelines give guidance on these sorts of underlying assumptions? Maybe you can elaborate.
I can't much elaborate. So we basically, so the quick answer is no. So the guidelines don't go into this very detailed, specific things that are more related to how do I model some specific events. So we don't, and I know there are different ways of how you can approach it. I'm not entirely sure I fully get the challenge that you're facing, Matt. But I think that's basically just to say there are different ways of how we model survival, and then we should for sure not get unrealistically long life expectancies.
Perfect. Thank you, Beata. I have a question for, I think this one is suited for Manoir. On one of the last slides, you mentioned an interpretation guide for decision makers, which I think is going to be very important. Is this available? If it's not available, when will this be available? And what should decision makers expect from this guide?
Yeah, thanks for that question, Wendy. So the interpretation guide has been reviewed by NACI, but it is not publicly available just yet on our website. We are hoping to post it in the coming months. But essentially, this document is our primary audience for this document is decision makers. And so it goes through in a very quick way different key concepts related to health economics. So for instance, it goes through what an incremental cost effectiveness ratio is. It goes through what QALYs are, so quality adjusted life years, similar to the primer that Beata had given in this presentation. It goes through what a sequential analysis is, how to interpret a cost effectiveness plane, how to interpret a cost effectiveness frontier. So essentially it goes through typical types of results and figures and tables that one would see in the results section of an economic evaluation. And we're going, in this document, we walk the audience through how to read those figures and tables, as well as what the interpretation should be. Should, if we see a result of X, should the decision maker be adopting or rejecting or trying to assess further a particular intervention in terms of its cost effectiveness? So it is written for a lay audience, and it's written in bullet forms, and it uses a lot of diagrams and so forth. So we hope it's a guide that's easy to understand. And again, we will make this publicly available, not just for NACI decision makers, but for decision makers in general. And we'll make that publicly available on our website soon.
Perfect. Thank you. Next question is for Beata. So for the economic guidelines, you presented a fairly lengthy impact inventory of various health and non-health impacts to include in an economic evaluation. And you've already mentioned on that slide that the expectation is not that every impact needs to be included. So if sometimes the data are not available or are of poor quality, it's simply not possible or unwise to include those impacts. Could you please elaborate a bit on that?
Thanks, Mandy. Yeah, just maybe briefly. So it's as I mentioned before, so it's intended to be comprehensive and kind of mostly kind of stimulate the thinking of what should be included and what may be relevant. And so then the analyst would have to make a decision what actually really goes into it, and maybe very practical considerations like that we don't know how to value some kind of outcome. And so with the inventory, it just allows us to really say, yes, we have included this in the analysis, or no, we have not. And especially if not, to provide some kind of rationale of why. So I think that will help others to acknowledge that actually it might be an impact that's important to consider in the future, that maybe it's something where we need to collect data. Would also help NACI to kind of just see and say, okay, it's, the analyst was unable to put a dollar amount on it, for example, but it's something that we should consider in our deliberations and discussions, and that may have an impact on our decision. So that's entirely possible. To the point you mentioned around the data, so I think so sometimes, like I said, it's just not possible to value something, but having poor data and sometimes even not having data on some things that are really important should not prevent us to not include it. So I'm basically coming from the perspective that if we don't include something altogether, we may bias our analysis one way or another. It's always possible to include something, and maybe there is a lot of uncertainty on that. So maybe we are not really sure about if some of the impact of the vaccine on some of the outcomes, or maybe it's something along the disease history or trajectory where we don't have good data on. But then doing this type of modeling and analysis and doing a really good sensitivity analysis will actually help us figure out whether that is something that is potentially really important and we should get data on, or maybe, it doesn't really matter. So occasionally we have things in a model, we have variables where there's a lot of uncertainty, and if we test over a reasonable range, it doesn't change our fundamental conclusion, and that's also information that's important. So yeah, I think that's pretty much it. I think I would just encourage analysts to really include what's relevant, and if there are reasons why not, to kind of fill in this inventory so that we learn more about why and why not, and what the impact may be, and can consider it in our conversations.
Perfect. Thank you, Beata. So Manuel, one last question before we conclude, and I'm going to ask you to be fairly brief, and this is more general. What is the role of mathematical modelers in contributing to economic evaluations, or NACI in general?
Yeah, thanks, Wendy, for that question. As you know, NACI works with a slew of external experts, including mathematical modelers, and we need these researchers and experts to help us answer various questions like number needed to vaccinate, or number of hospitalizations prevented, ICU admissions prevented, or deaths prevented. So when the Secretariat is conducting its environmental scan of what's in the landscape, we want to identify existing models as well as models under development, and we do want to engage with various researchers out there, including mathematical modelers and health economists, who can help contribute to some of this work, help us with the help us in terms of bringing more evidence into our evidence package that is going to NACI for their deliberation.
Thank you so much. So thank you again to Beata and Manuel for your presentations today, and to everyone who was able to join us for this webinar. If you have questions for Beata and Manuel that didn't get answered today, please feel free to send them to nccid@umanitoba.ca, and we will pass them along. The recording from today's webinar will be available soon on the NCCID website. And if you would like to learn more about the new NACI guidelines in a slightly different format, we also have a published podcast episode on the guidelines with Beata and Manuel, which I highly recommend. And you can find the podcast under the webcasts tab on the NCCID website. Also, please take a moment to fill out the short evaluation, which will be sent out immediately after this event. It will help us to plan future events. So thank you all again, and enjoy the rest of your day.